right, we're going to go ahead and get started with today's webinar. So welcome to the 2020 webinar series hosted by the Center for Sport, Tulane University. Today, we are very fortunate to be featuring presentations from the Tulane Women's Sports Medicine program. We have a great lineup. We will have 3 shorter presentations followed by a panel discussion. All centered around ACL tears in the female athlete. So before we introduce our presenters, I wanted to take a little bit of time to do some housekeeping. We have the Q&A feature activated. So if along the way throughout the webinar, if anyone has a question, please feel free to type the questions in there. And we will address those during the panel discussion at the end. At the end, we'll also have some contact information for follow-up information in line with the evaluation for today's presentation and discuss how you will receive your credit for continuing education. So I want to thank everyone for being here. And before we get started, just a little bit about the Center for Sport at Tulane University. So the Center for Sport is a center on Tulane's campus that is backed by Tulane University and holds relationships with local, national, and professional sports organizations. The Center for Sport has developed an interdisciplinary network of resources that's centered around knowledge and experience all under one roof. And it puts us in a unique position to look at and view sport from a 360-degree perspective. Our work promotes cross-campus collaborations and connections that allows us to examine crucial problems facing athletes, sport, and society, as well as develop careers and innovative answers to issues that affect the sports industry. We have 3 key missions at the Center for Sport. We look to educate current and future professionals in the areas of sports industry, improve the emotional and physical lives of athletes by advancing cutting-edge sports research and health services, as well as inspiring social change by promoting powerful impact of sports and the role that athletes play in the community. At this time, I will hand it over to Dr. Greg Stewart, who is one of the co-founding directors of the Center for Sport, and he will be introducing today's presenters.
Thank you, Tess, and thank you for all the work you do in putting these webinars on. Very much appreciate that. And today we are talking about ACL tears in female athletes. We have a very strong panel. First, Dr. Mary Mulcahy, board certified orthopedic surgeon, specializing in shoulder and knee surgery and sports medicine. She's a New Hampshire native who received her Bachelor of Arts in Biochemistry from Dartmouth in 2000 and her Doctor of Medicine from the University of Rochester School of Medicine in 2006. She completed orthopedic residency at Brown University, followed by a fellowship in orthopedic trauma at the same institution. Dr. Mulcahy then went on to do a fellowship in sports medicine at San Diego Arthroscopy and Sports Medicine. While in fellowship, she assisted with team coverage of the San Diego Padres of Major League Baseball and San Diego State University. Dr. Mulcahy joined the faculty in the Department of Orthopedic Surgery at Tulane in April of 2017 as the director of Tulane Women's Sports Medicine Program. In that role, Dr. Mulcahy has been instrumental in the design, development, and leadership of a comprehensive approach to the care of active women. This cutting-edge program combines resources and services of multiple disciplines, including orthopedic surgery, primary care sports medicine, physical therapy, nutrition, and sports psychology. Dr. Mulcahy is the team physician for Tulane women's indoor and beach volleyball teams, the Big Easy Roller Girls, New Orleans women's rugby, the Half Moons, the Hurricanes, the women's professional football team in New Orleans, as well as several local all-girls high schools, including St. Mary's Dominican, Academy of the Sacred Heart, Cabrini, Mount Carmel Academy, Archbishop Chappelle, and St. Scholastica Academy. Today, she'll be joined by Krista Calley, who started working as a physical therapist with PT Solutions in partnership with the Tulane Institute of Sports Medicine in the summer of 2016. Prior to this, she practiced at Champion Sports Medicine, where she worked closely with the physicians at the Andrews Institute. She served as clinical director and played an integral role in outreach at local high schools. Before this, she worked at ISR Physical Therapy in the New Orleans area, where she became familiar with orthopedic conditions and industrial medicine. She's an orthopedic clinical specialist and is trained in dry needling, manual therapy, McKinsey, Maitland, and ASTEM. Krista currently treats primarily orthopedic and sports conditions at the Metairie Clinic. She enjoys being active and does so through CrossFit, Pilates, and soccer. Welcome. Renee Boudreau joined Tulane Institute of Sports Medicine in July of 2019 as an outreach athletic trainer to her alma mater, St. Mary's Dominican High School. She has recently transitioned into a clinical athletic trainer role at the Tulane Institute of Sports Medicine. Prior to joining TISM, she earned her Master of Science in Organizational Leadership from Mercer University in Macon, Georgia. While at Mercer, Renee worked as the graduate assistant athletic trainer for the women's soccer, cheer, and dance and men's soccer teams. Before graduate school, Renee graduated from the University of Southern Mississippi with a Bachelor of Science in Athletic Training. This curriculum and clinical work allowed Renee to see a variety of injuries and illnesses in sports varying from football, baseball, track and field, and 2 high schools in the Hattiesburg area. She's a native New Orleanian and has been enjoying festing in place and concert streams that have been playing during the quarantine. And Taylor Lyles will be joining us in the panel. She currently serves as the Tulane University Club Sports Athletic Trainer and joined the Tulane Women's Sports Medicine team in the fall of 2019 after serving as an assistant athletic trainer at Loyola University in New Orleans from 2017 to 2019. Prior to her time at Loyola, she earned a Master of Science in Advanced Athletic Training from the University of South Carolina in 2017 and a Bachelor of Science in Education and Athletic Training from the University of Miami in Florida in 2015. Welcome to all of you. And at this point, I'm going to turn the program over to Dr. Mulcahy. So Dr. Mulcahy to talk in ACL tears in female athletes.
Great. Thank you so much. I will start this. All right. So thank you so much, Dr. Stewart and the Center for Sport for hosting this webinar. We're really excited to be here and to be able to share this information and really looking forward to the discussion at the end. So I'm going to be focusing on ACL tears in female athletes and specifically risk factors, outcomes, and factors that influence return to play. These are my disclosures, none of which are directly relevant to this talk. As some learning objectives, we are going to be, where we hope that by the end, you're going to have a better understanding of the factors that contribute to an increased risk of ACL tears in female athletes, that you're able to discuss criteria that are used to determine return to play after ACL reconstruction, and that you're able to explain the different psychological factors that influence readiness to return to play. As a brief outline, I'm going to talk about the risk factors for ACL tears in female athletes, breaking them down into non-modifiable and modifiable risk factors. I'll touch very briefly on injury prevention programs. Renee is going to go into much more detail on that. And then I'll discuss factors that influence return to play and outcomes following ACL reconstruction. So we know that the majority of ACL tears are the result of non-contact injuries and really occur as a result of sudden deceleration and change in direction in sports that involve landing, cutting, and pivoting, like soccer, volleyball, and basketball. In terms of non-modifiable risk factors, these include sex differences in knee geometry. So increased Q angle, decreased notch width, the decreased width and length of the ACL. Notably, the width of the ACL is proportional to the notch width only in men. And then I included here at the end, increased posterior tibial slope. There's a lot of research in the orthopedic literature talking about this, and it has definitely been demonstrated that an increased posterior tibial slope, especially the lateral posterior tibial slope, is a risk factor for ACL tears in both male and female athletes. I just wanted to make note of that. Hormonal variations are also a very important non-modifiable risk factor. So we know estrogen and progesterone levels rise and fall throughout the menstrual cycle. And sex hormone receptors are found on several tissues, including skeletal muscle, connective tissue, and bone. Estrogen alters collagen metabolism and structure, and some studies demonstrate that women in the pre-ovulatory phase are at increased risk for ACL injuries, but really it's unclear how fluctuations in sex hormones alter the structure and function of the ACL. There's a lot of research ongoing about this. This is a study that was published recently in the Orthopedic Journal of Sports Medicine. The authors in this case wanted to provide clinically relevant and evidence-based recommendations on the use of hormonal contraceptives in female patients who are at high risk for musculoskeletal injuries. They performed a systematic review and evaluated several databases. They identified 7 studies that evaluated oral contraceptive use and soft tissue injury risk. Of those, 2 had high quality of evidence scores, and they showed that oral contraceptive use decreases the risk of ACL injury and decreases ACL laxity. Based on that, the authors concluded that the higher quality studies suggest that oral contraceptives can decrease ACL laxity and decrease the risk of ACL tear in female athletes, and therefore oral contraceptives may serve a therapeutic role in decreasing the sex disparity in ACL injury rates. You do, of course, have to take this with a grain of salt because it was only 2 high-quality studies, but it does show some promising evidence and reason for there to be ongoing research. In terms of modifiable risk factors, the first are neuromuscular control. So female athletes have a quad dominant deceleration pattern and weak hamstrings. So what that means is as female athletes slow down, the quads are activated, which in turn pulls the tibia anteriorly. Now, because the hamstrings are weak, they can't really counteract that movement. And so that places a lot of stress across the ACL. Core strength is also a contributing factor. Biomechanical factors are additionally very important. There are sex differences in landing patterns that are important to take into account. So women have increased valgus alignment, that is also known as increased knee abduction moment, or basically landing knock-kneed, right? Additionally, female athletes tend to land with decreased hip and knee flexion. So you can imagine just landing with stiff legs. This picture, I find it very difficult to look at, but this is in general how female athletes land, right? So you can see in the center image there, landing knock-kneed, and that places a tremendous amount of stress across the ACL. It's thought that some of these factors are related to core strength and proprioception. And this is what we focus on in injury prevention programs because we can actually make a difference with these. So injury prevention programs, again, modifiable risk factors is what we want to address. So the specific biomechanical and neuromuscular risk factors are that increased knee abduction angle, limited hip and knee flexion, landing, asymmetrical landing patterns, and abnormal ground reaction force. So just touching briefly on one study, this is a study published last year where they wanted to evaluate the common and effective components included in ACL neuromuscular training programs and to develop an efficient user-friendly tool to assess the quality of ACL neuromuscular training programs. So they performed a systematic review and meta-analysis. They identified 18 studies that included about 27,000 patients. 347 of them had an ACL injury, and they found that neuromuscular training reduced the risk of ACL injury from 1 in 54 to 1 in 111. They also noted that interventions targeting middle school and high school aged athletes reduced the injury risk to a greater degree than for college or professional age athletes. So a key point there is that introducing these programs at a younger age, I'd say ideally middle school, there's a lot of studies supporting that, is most effective. So the key is to catch these girls before they go through puberty. They also found that increasing landing stabilization and lower body strength exercises during each session improved prophylactic benefits. So it's a mix of exercises that's most effective. They concluded that ACL neuromuscular training programs should absolutely target younger athletes. Using trained implementers is very important. So like an instructional workshop, and Renee is going to expand on a lot of these things. Incorporating lower body strengthening like Nordic hamstring and lunges was very effective. And an important component of this is to focus on landing mechanics. They also noted that it's very important to incorporate these exercises throughout the season and not just during the preseason. So in terms of return to play, this is a little bit of a busy table. I'm going to break some of these things down on subsequent slides. The key thing is that there are pre-op, intra-op, and post-operative factors that can influence return to play following ACL reconstruction. And all of this is from a study published in 2015. So in terms of preoperative, pre-op rehab, or prehab, as we sometimes refer to it as, can be very beneficial. So this can be used to reduce pain and swelling, help restore range of motion and neuromuscular control, normalize gait for these athletes, and prevent muscle atrophy. So I tell my patients with ACL tears and before going into surgery in general, right, how they go into surgery affects how they come out. And this is especially true for these patients with ACL tears. So for patients coming in with a really swollen knee and limited knee range of motion, I absolutely send those patients to physical therapy before we proceed with ACL reconstruction. I want their range of motion to be normal and the swelling to have gone down. In terms of intraoperative factors, the ideal graft, graft choice in general is very important. The ideal graft has secure fixation, causes minimal morbidity to patients, and allows for early, safe post-op rehab and timely return to play. Commenting briefly on bone, patellar tendon, bone grafts, healing because of the bone in the tunnels occurs by about 6 weeks. There are a lot of studies comparing different graft choices, and I'll comment on one of those, but in general, there's no objective difference between BTB and hamstrings long-term. This study was published in 2019, and they wanted to evaluate the outcomes of quad tendon autografts. They reviewed clinical studies comparing quad tendon autograft versus BTB and hamstring autografts with regards to several parameters, including stability outcomes, functional outcomes, donor site pain, and graft survival. They identified 27 studies with about 2,900 patients who had undergone ACL reconstruction. When comparing quad tendons to BTB, there was no significant difference in several parameters, including graft failure, side-to-side difference. But they did note that patients who had quad autograft had less donor site pain. When comparing quads with hamstring autograft, there was no significant difference, again, in many parameters, but patients with quad autograft had improved mean Lysholm scores. They concluded, therefore, that quad tendon autograft had comparable clinical and functional outcomes and graft survival compared with BTB and hamstring autografts, but that quad autografts showed significantly less harvest site pain compared to BTB autografts and better functional outcome scores compared with a hamstring autograft. So quad tendon autograft definitely has become a lot more popular in the past 5 years or so. And for me personally, this really is my go-to autograft. It's a very reliable graft and really robust. Patients tend to do very well. In terms of post-op, of course, a reproducible rehab program is critical. Krista is going to go into detail on what is involved in post-op rehab. There are some studies that comment on accelerated rehab, whether athletes can get back to play faster if they go through rehab faster. The bottom line is they really need to meet specific goals in order to progress through the phases. And that's the most important thing, rather than looking at a specific time point. Also important to keep in mind that prior to advancing to the next phase, right, the athletes have to meet specific criteria, including range of motion, strength, neuromuscular control, functional tests, and being able to do a lot of this under endurance, like a condition of fatigue, because that's what they're going to need to do when they're back on the field or back on the court. In terms of a functional sports assessment, you can include things like hop testing, a single leg squat, lateral agility and pivoting drills, drop to jump, which is demonstrated in this video, and deceleration drills. So these are some different things that can and are frequently incorporated. Now, a very important thing to keep in mind are psychological factors and how they can influence return to play. So routinely, post-op rehab focuses on treating the physical problem. So range of motion, strength, right? That's really what we focus on at physical therapy. The psychological aspects are often neglected. But by identifying psychosocial factors that influence return to play, it can give us a much better understanding of an athlete's readiness to return to play from a psychological perspective. This recent study in AJSM wanted to determine whether psychological readiness to return to sport is associated with a second ACL injury. And the authors hypothesized that at both pre-op and 12 months post-op time points, patients who sustained a second ACL injury would have lower psychological readiness than patients who did not have a second ACL injury. They looked at patients undergoing primary ACL reconstruction from June 2014 to 2016. They had these athletes complete the ACL return to sport inventory short version before surgery and at 12 months post-op. They followed all of them for 2 years, a minimum of 2 years, and their primary outcome was the relationship between their return to sport inventory and the incidence of a second ACL injury. They found that 329 patients returned to sport after ACL reconstruction. 16% of them sustained the second ACL injury. They did not find any difference in psychological readiness at pre-op, but patients with a second injury trended towards lower psychological readiness at 12 months compared with non-injured patients. For younger patients, i.e. under the age of 20, those that had injury had significantly lower psychological readiness to return to sport than young non-injured patients. They found no difference in older patients. And also they identified a cutoff score of 77 points, showing 90% sensitivity to identify younger patients who sustained a second ACL injury. Based on that, they concluded that younger patients with lower psychological readiness are at a higher risk of sustaining a second ACL tear after return to sport. And those with a score under less than 77 are at higher risk for a recurrent injury. They also commented that psychological counseling may be necessary to be performed in parallel with their physical therapy and that physical recovery to improve the success of return to sport and reducing the risk of a second ACL injury. Now, commenting specifically on some of the psychological factors, so self-efficacy refers to an individual's judgment of his or her ability to carry out a task. And we know that higher self-efficacy is associated with a more positive outcome after rehab, higher confidence in one's ability to complete tasks, and a higher adherence to rehab. This can be measured with a validated score known as the Knee Self-Efficacy Scale. Fear of re-injury is the primary emotional factor affecting return to play, and you'll see this frequently mentioned in studies. It's closely associated with kinesiophobia, which is a heightened fear of movement and subsequent re-injury. This is also associated with lower self-reported knee function and lower rate of return to play. Taking into account an athlete's or a patient's expectations and assumptions about recovery is really important. So their initial expectations may be skewed, and oftentimes these patients are not fully prepared for rehab. When they have unrealistic expectations, that leads to decreased confidence and decreased self-efficacy. So it's very important for us as a team, physicians, orthopedic surgeons, athletic trainers, et cetera, to try to help the patient understand what to expect at the time of surgery, immediately post-op, and then as they progress through their rehab. This is another recent study from 2019 focusing on expectations for return to sport. And this was before and after ACL reconstruction. They wanted to determine factors associated with changed expectations. They found that 84% of patients expected to return to pre-injury level of sport. So the expectations are incredibly high. The expectations were slightly lower for patients undergoing revision ACL reconstruction, which is understandable. At 12 months post-op, 24% of patients who expect to return to sport had returned, and 9% had decided to give up sport because of fear of re-injury. They also found that factors associated with the decision to give up sport were female sex and having undergone previous ACL reconstruction. Based on that, the authors concluded that patients have very high expectations for return to sport after ACL reconstruction. The expectations, though, are lower for those who have undergone previous ACL reconstruction. And female patients, as well as those who've had previous ACL reconstruction, were more likely to change their expectations and stop playing sports. So the goal is that we can use this information to provide our patients with more realistic expectations in terms of return to sport. A couple brief comments about outcomes after ACL reconstruction. So studies definitely show that there are abnormal lower limb movement patterns and neuromuscular control during jump landings, even after rehab and return to sport, which can increase the risk of a second injury. We also know that female athletes with ACL reconstruction have re-injury incidence that is 16 times greater than healthy female athletes and 4 times greater than male athletes who've had ACL reconstruction. Some take-home points: the risk of ACL injury is much higher in females than male athletes, upwards of 8 times higher. And that's because of a combination of non-modifiable and modifiable risk factors. In terms of modifiable risk factors, we focus on these in our injury prevention programs. So injury prevention programs have been shown to have a protective neuromuscular effect on the risk of ACL rupture. It's the combination of exercises that's most effective, and focusing on younger athletes and incorporating the exercises both preseason and in season is most effective. With return to play, there is currently a lack of objective standards. There are some criteria that we use, but it is quite variable from surgeon to surgeon. Females tend to have poorer outcomes than males, and very, very important to remember and take away from this talk, psychological factors absolutely influence recovery and return to play. I'd be very happy to answer any questions during the panel, and thank you so much for your attention and joining us today.
All right, thank you, Dr. Mulcahy. At this time, I'm going to turn it over to Renee. And she's going to upload her presentation and take it away.
Thank you, Tess. Okay, hey all, thank you for joining us today. I'm Renee, and I'll be talking about ACL tear prevention for the female athlete. So first, before we start, I just want to state that I have no financial relationships with a commercial interest to disclose and no conflicts of interest to resolve. So hopefully by the time we're done today, you'll be able to identify and overcome barriers to ACL prevention implementation, identify effective training techniques and exercises for a successful preventive training program, and recognize and utilize appropriate tools for ACL PTPs. Okay, so prevention is super important. Looking at numbers, long-term cost effects, it can cost up to about $83,000 for your athlete or your patient if they do experience an ACL tear. There are often other injuries associated with an ACL tear. More than half the time there's meniscus involvement, and about 16 to 46% of the time there is cartilage involvement. Also, this can lead to a quality of life impairment that can occur 5 to 25 years down the line. This can include osteoarthritis or a total knee replacement, as well as just general aches and pains that your patient will experience throughout the day. Females are 3 times more likely to rupture their ACL, and there's also a substantial risk factor for a second tear. This can be contralateral or ipsilateral. There's also lower return to play rates in the female athlete. So looking at athletes below the age of 25, there's a 39% return to play rate for females compared to a 52% return to play rate for males. And they also obviously will suffer time loss from sport and activities that they love. So in order to prevent that, we need to implement preventive training programs. So looking at one study, female collegiate athlete awareness of PTPs, the majority of them reported that they are aware of an increased risk in females. However, less than half of them were aware that a preventive training program existed. And of those, only 15% reported prior preventive training program participation. It was also reported that 89% of them were willing to perform a preventive training program if they knew that this would help them reduce their risk of tearing their ACL. It should also be noted that most of the respondents were more willing if they had themselves experienced an ACL tear or if a teammate had experienced a tear. The respondents were mainly from Division I and Division III, and it was noted that the Division I athletes were more aware and likely to have participated in a PTP. So this tells us as clinicians that we should do further research into why this may be. It may be that at the Division I level, there's more access to one athletic trainer to one sport, so you have a little bit more availability, resources, and time. But also just look at, what level were these athletes playing growing up, and what did they have access and resources to while they were growing up and developing. So it shouldn't just be our Division I athletes that have this exposure. We should take care of all of our athletes. This is the survey that they responded to. Did they have do they know what an ACL injury is? Have you ever sustained one? And would you be willing to perform a daily exercise program if you knew that it could help prevent an ACL tear? Okay, so a couple barriers to success. Overall compliance is key. If you don't comply to the program, that's essentially non-effective. So some things that contribute to the compliance to success, first of all, would be implementer confidence. So usually it's a coach that is overseeing this and implementing it. So we need to make sure that they are confident in what they are doing. It's been found that if we provide them with a workshop that's interactive, where they themselves can perform the exercises as well as watch other people perform them, this helps them because they know what it should feel like, what it should look like, and things to look for when overseeing their team, as opposed to if you just hand them a pamphlet and say, you know, this is an ACL tear, this is the exercises you do, but there's really no hands-on experience. They're not confident in what they're doing, and they're much less likely to continue to implement the program. Another issue is time. This can sometimes be the length of the practice itself, the season length, how many games are played in a season. All of those things contribute. Coaches, we all know, they like their time. They don't want it to be taken away. So one thing that's been helpful is you, instead of doing a typical warm-up, you replace that warm-up with your preventive training program. As Dr. Mulcahy touched on, super important to start this at a young age. It has been found that high school coaches are more successful with implementing this, and one of the things that can lead to that is their length of season. It's typically longer than a middle school season. They typically have more access to their athletes, but it is super important, like Dr. Mulcahy touched on, that we start this at a young age. Stakeholder buy-in is also crucial. You want buy-in from your coaches, your athletic directors, your parents, and even the athletes themselves. The sooner you start this and make it more widely accepted and expected, more consistent prevention programs will become. Okay, let's see, things to consider. So first, you want to identify modifiable risk factors like Dr. Mulcahy touched on. These can include your abduction angles, your limiting deflection, your ground reaction force, as well as your hamstring strength. Usually you want to touch on that with eccentric control. It's been found that that's really effective. BFA 11 Plus is a preventive training program that has been widely accepted and utilized. It's been found that 35% reduction rate with a high compliance. It's important to note that 35% is with high compliance. Intermediate compliance has not been as effective. You typically want to do this at least 2 times per week. It's also important that you incorporate a variety of exercise types. So it's been found that just balance or just plyometrics or just strengthening really don't do anything for you. You need to do all of them within conjunction of each other. Some good things to do would be box jumps, Nordic hamstring curls, lunges, monster walks, lateral walks. We want those hamstrings to be strong and able to provide a counter force to the anterior force placed on the quads, or placed on the knee from the quad, sorry. It's also important to provide feedback. If you can do this verbal or visual, that would be great. Everyone learns differently, but some things to help them would be saying things like land like a feather, especially when they're landing. We want them to bend at the knees, bend at the hips. We want to keep the hip, knee, and feet in line. The stiffer that they land, the more at risk they are for tearing their ACL. It's been shown that plyometrics, after about 6 to 9 weeks, there's been a reduction of about, I believe, 17 to 26% in ground reaction force after plyometrics, which is good because the higher ground reaction force you have, the greater risk you're at for an ACL tear. Okay, so looking at the 11 plus, we'll kind of break this down a little bit, but you can see that there's 3 parts. This again, it was designed to be replaced, to replace the typical warm-up. You want to do this prior to every practice, and you want to do parts 1 and part 3 prior to every game. So part 1, all of your running exercises. So you're going to have straight ahead, hip out, hip in, circling your partner, shoulder contact, and quick forward and backwards. So make sure that when you're running straight ahead, your hip, your feet, and your knees are in line. You don't want your knees to drop in. Hip out and hip in, you want to make sure that your core is tight, pelvis is in line, and shoulder contact. When you do that one with your partner, you want to make sure that you're reinforcing that they land with flexed hip and flexed knees. Again, the straighter the leg is, the more at risk they are for a tear. Looking ahead at part 2, it's going to incorporate your strength, your plyometrics, and your balance. You can see that there are different phases. So level 1, level 2, and level 3. Ideally, you'll progress individually. Sometimes can be a little bit challenging. You shouldn't progress to the next level until you're able to competently and correctly perform the exercise. If needed, you could progress as a group after about 3 to 4 weeks, or you could progress as a group, but if specific exercises need to be held back for certain people, that would be okay too. So looking at the bench, you're going to start in phase 1 with static. So this is just basically a typical plank. You want to make sure that your head, your neck, your trunk, hips, and knees are all in line. Once you can confidently do that and do it correctly, you will then progress to level 2, which means you're going to alternate your legs. And so you're going to do about 3 sets, hold it for 40 to 60 seconds. But with the alternate legs, you will raise one leg, hold it for 2 seconds, then you'll switch to the other, and you'll do that the whole time. Again, once that can be comfortably and competently and correctly performed, you'll move on to phase 3. This one, you'll start with one leg in the air, and you'll hold it the duration of the set. Looking at the hamstrings, you're going to perform the Nordic hamstring curl. Beginner, intermediate, and advanced, it's all the same thing. You want your head, your core, your hips, your trunk, everything to be in line. The only motion that should be occurring will be occurring at the knee. The only thing that will change is their number of reps that they're doing. Vertical jumps, lateral jumps, and box jumps. Again, you want to make sure that you're landing with good control, that your hips and your knees are flexed and in line. Box jumps, it's not really what you would think. You're jumping up on a box. You're actually jumping diagonally and backwards, forwards, and in the shape of a box. Then you'll end it up and wrap it up with running exercises where you're running across the field, bounding, and you're planning and cutting. It's important when you're bounding, land on the balls of your feet. You want your leading leg to be flexed as much as possible. The plant and cut, you'll alternate between cutting on the left and the right. You will take about 2 to 3 yards of an 80 to 90% maximum sprint in between each cut. And again, make sure that everything is in line and we don't let that knee fall in. Okay, there are 7 steps as a guideline that were developed for successful implementation. Step 1 and 2 kind of go hand in hand. You would like to establish administrative support and develop an interdisciplinary team. There's been studies revealed that looking at people that have utilized a 7-step program, that only 25% of people attempt to establish administrative support. And if you don't have that, then you're really setting yourself up to have a hard time of successful implementation. So you want that interdisciplinary team to consist, again, of your coaches, your parents, your athletic directors, and anyone else that's really super involved with your team. Looking to step number 3, they're going to help you identify barriers to success that you yourself may not have thought of. Sometimes it's time, it's money, it's resources. Where and when are we going to do this? And those people may have solutions that you yourself may not have identified. Looking at step number 4, you need to identify an evidence-based preventive training program. You can use the FIFA 11 if you would like. There are other programs that you can utilize, or you could come up with your own. But make sure that you're incorporating all different types of exercises. Again, like we talked about, you want to train the trainers and the users. If the people that are implementing this are not confident in what they're doing, it's less likely that it's going to be implemented throughout preseason and in season. It's really the only way it's been shown to be effective. Preseason alone isn't going to do much for you. Preventive training program fidelity control. Super important that not only are you consistent with doing this, but that you're doing all the exercises correctly. So that's just as important as doing it. If you're not doing it consistently, you're not doing it correctly, you're really not getting the benefit that you could be. And then looking at the exit strategy, you want to know, how is this going to be maintained, and have you had good compliance for an extended period of time? So a few things to remember. Compliance is key. Begin the preventive training program at a young age. Identify unique barriers to success. This can vary from team to team, sport to sport, even school to school. Make sure you incorporate plyos, balance, strength, resistance, and trunk control. Find a program that works for you and for your athletes, and make sure that everything that you're doing fits the 7 steps for successful implementation. Here are all my references, and I'll be happy to answer any questions you have after the panel. Thank you.
Thank you, Renee. At this time, we're going to turn it over to Krista, who is going to share her presentation with us. And Krista, you want to go ahead and upload your presentation?
I'm Renee 2.0. I had some technical difficulties, so you will not see my name appear under my face, but I'm here nonetheless. All right, so I'm just going to speak to physical therapy following ACL reconstruction. I am a physical therapist at PT Solutions, and we work in partnership with Tulane. So I have nothing to disclose. Today's talk is truly tip of the iceberg. I know it's cliche, but I could probably do a weekend course on all of this information. There's a ton of research out there. So I'm just going to, hopefully by the end of today's talk, allow you to name the main phases of rehab following ACL reconstruction, understand the goals for each phase, and know appropriate interventions. And then also be able to identify social factors that might impact a patient throughout the course of her treatment. So some things to consider. You want to establish a patient rapport day one. It's crucial. You will be with this patient for a long period of time, and if you do not gain her trust or her family's trust, then it's going to be an uphill battle for you throughout rehab. You want to know what the family support is like. So what's the picture like? Are mom and dad involved? Are mom and dad away because you're dealing with a collegiate athlete who is trying to return to her sport? Those are all things that you have to understand in order to develop your relationship with the patient. You want to create patient-centered goals. So if a patient's trying to return to a particular sport, you want to make your goals relevant to that sport, not just a generic cookie cutter goal. And then you have to communicate with the referring physician and the athletic trainer that works with that patient, because you all want to be on the same page in order to get her back to where she needs to be. So in addition, you need a good medical history. So sometimes patients have medical history that they don't believe is significant to her current injury, but it is. So you really need to dig deep and make sure you've got all information, because there are many other factors and other health conditions that will negatively affect rehab. You want to understand the mechanism of injury. Was it contact? Was it non-contact? When was the injury? Did the patient have to sit out for 2 months without any treatment because of maybe a global pandemic? Or, was she just unable to get insurance approval and didn't have therapy or any sort of prehab before surgery? And then you want to think of the type of repair. So that's going to have some implications. For instance, a hamstring graft and a hamstring autograft, you're not going to stretch the patient's hamstrings day one. Or a patellar tendon autograft, you want to beware of patellar tendinopathy that could develop later on in physical therapy. And then just any additional procedures. So was the patient's meniscus involved, MCL, LCL, was there bony involvement? And these things will all give you some information as to how fast or how slow you can progress through rehab. So phase 1 is weeks 1 through 2. You should see this patient walk into your door post-op day 1 or maybe as late as post-op day 7. Extension, I can't emphasize it enough, is crucial. So here's a picture of a patient doing a heel prop. You can add some weights to the patient's thigh for some overpressure, but you've got to get good extension on a patient, or else all other goals will be difficult to achieve early on and even later in the game. And you've got to get your patient working on some of these things on her own too. She shouldn't just rely on you. So you want to get good quadriceps activation and strength early on. Pictured here is an exercise, a multi-angle isometric quad exercise. So a lot of times we'll do quad sets with the knee flexed to 0 degrees, flat knee. But you want to think of strengthening in different planes, because when you get your patient off the table, she's got to be able to activate her quad in different positions. You want to control swelling. Any bit of swelling is going to shut down the quad and alter the joint mechanics and range of motion. And then you want to ensure that the patient has good patellar mobility, scar mobility, patellar fat pad mobility, so that whenever you're working your way through range of motion, you don't have any limitations. And then you want to try to restore the gait pattern as soon as you can. So take that brace off in PT, get the patient walking and moving. You've got to get her comfortable with accepting weight through her limb and comfortable with doing activities on that side, because as Dr. Mulcahy and Renee touched on, you've got to instill confidence in this athlete. Otherwise, risk of injury is just going to shoot up. So again, beware of the extensor lag. So these are 2 pictures just showing a patient who has an extensor lag on the left. So her left leg sits up higher than the right, and you can take a measurement in this position, and it's a heel height difference referenced in the literature. So moving on to phase 2, this is weeks 2 through 4. So you're doing a lot of the same stuff, but just progressing a bit. Quad strength, so I didn't show a picture of electrical stimulation on the first phase slide, but you'll probably implement this initially, and you might still be using it in this phase dependent on how your patient's quad activation looks. But you can get that patient off of the table and do the electrical stimulation in functional positions, like in a squat or doing a step up stair training, doing a wall sit. And then you want to progress your closed chain exercises. So that's all that functional movement that I'm referencing, doing things that are kind of everyday activities like bending down to get something, going up and down stairs normally. You want to be able to restore balance and proprioception. So you've got to get neuromotor control of the limb. And you can do this through unstable surfaces, through doing exercises with eyes closed, through getting the patient on one leg and doing exercises. You need to maintain that knee extension throughout. Make sure that you don't leave that. You want to be able to check that patient's knee extension and ensure that it's staying where it needs to be. And in this phase, we want to see flexion to 120 degrees or greater. Now, of course, this goal might change if the patient had a meniscus repair, but that's something that, like I said, you look at everything and the whole patient and you tailor these goals according to her. So normalize the gait pattern if you haven't gotten there yet, because you've got to prep for the next phase where the brace will be discharged and your patient will be walking without it. And then don't forget about the unaffected limb. Oftentimes we see that patients have an ACL tear on one limb and then they return to sport and they have a subsequent tear on the contralateral limb, and we don't want to see that. We've got to remember that in order to get our patient back to sport, she needs both legs. So you've got to look at the strength and control of the unaffected limb too. Moving on into phase 3. So this is weeks 4 through 12. You want full knee range of motion here, so full extension to flexion. Then you should have been doing core and hip strength all along, but you can start to advance these exercises and really challenge the patient through some of this. And we know that strengthening the core and hips will allow for better landing strategy, better performance during explosive and lateral movements, and all of those things are going to help to prevent future injury. Then you want to begin functional movements related to sports. So you want to really get sports specific here and look at, okay, my athlete who wants to return to soccer is going to differ from my athlete who wants to return to ultimate frisbee, who wants to return to softball. And you really need to specialize this, and this will help too with the patient's buy-in. So if I'm doing something and it's specific to her sport, she's going to buy into what I have to say and trust me more. So in this phase, usually the brace is discharged, but you want to make sure to communicate with the physician about this. So even though you know what the patient had done and you know the other factors involved, your physician really was in there and could see the quality of tissue, the quality of bone, if there was an injury, and will be able to tell you, okay, yeah, it's good to discharge it now, or no, let's wait because of X, Y, and Z. In this phase, we can begin light plyometrics as early as 8 weeks, and we can begin jogging at 12 weeks. So light plyometrics, what you want to think of is double leg activities, no single leg activities, and just jumping at a small height. So if you're having your patient jump off of a box, you start with a 2-inch box. You don't start with 20-inch box jumps on a patient in this phase. Moving into phase 4, this is weeks 12 through 16. So we can progress that jumping, and we can, in this phase, get into higher heights, getting into single leg jumping and landing, but you're staying in the sagittal plane. So you're staying up and down, and you're not doing any lateral movements or cutting here. You also want to implement strength training. So you can do this in your clinics if you're the physical therapist working with the patient, or you can utilize your athletic trainers that you have, or you can even utilize a strength and conditioning coach. So it's all that team-based approach, and you just want to provide the patient with what she needs. But if there's some way that you can use the time in physical therapy for something else, then you want to utilize those outside resources. It's in this phase that we start thinking about getting the patient a functional brace, and your physician should help you through that process, but you want to kind of prepare the patient for that. And then in this phase, we've got to remember that the graft is weakest at 3 months post-operatively because of tissue healing properties. So you want to progress all of these things, but you've got to know that you shouldn't progress something if a patient has horrible strength and bad trunk control and fear avoidant behavior. You've got to only progress it if she's solid on everything, because the graft isn't strong enough to hold her there. So here's just a graph talking about the healing of your graft. And you can see it's not until the 6 to 9 month mark that we see maturation of the tissue. Okay, moving into phase 5, this is week 16 plus. So you might discharge your patient between months 6 to 9, or you might be seeing her for 1 year. So this phase can really differ in a lot of people, but it's usually in this phase that we really implement return to sport testing. So you may have done some of this testing in phase 4, but it's here that we're really looking at the numbers and trying to get as close to that symmetrical strength, limb to limb as we can. So some of the things that we'll use here at PT Solutions in Tulane is the Vail Sport Core testing, HOP testing, and Biodex. Now there's many other things that you can use. I don't want you to think that I've listed these 3 as the end all. These are just some examples, and the picture over to the right is a picture of a Biodex test. So you want to continue to advance strengthening. So whether that's in the strength and conditioning program that your strength coach is working with your patient on, or whether it's something in the clinic that you're doing, you've got to continue to load your patient and load her muscle tissues. And then you can begin to work in frontal and transverse planes. So we can move out of the sagittal plane, and we can begin to do some lateral movements and some cutting. Just remember that graft maturation usually doesn't occur until that 9 month mark. Here's a picture of a patient doing some lateral movements, a slide board activity. She wanted to return to playing intramural basketball at Tulane. So we've got a basketball in her hands, getting her used to reaction. So here's some examples of exercises here. The patient is doing a single leg squat. So she's squatting down, tapping the cone with the basketball, and then coming upright and tossing it back to the therapist. So it's sport specific. We've got a band around just above her knee so that she can work out of knee valgus and activate those hips in order to get the work done. And then you can see in the picture on the right that we've added an unstable surface underneath her foot to help with that proprioceptive awareness. Next, we've got core exercises here. So this is some advanced core work. This is where you can have a lot of fun. So she's doing a side plank on the left, and she's adding a hip abduction leg lift to get those hip abductors working. And then she's also doing a row to work on some postural control. In the next picture, she's got her feet and arms on an unstable surface, and she's actually moving the ball around in a circle to add more difficulty to the exercise. And then we've got some plyometrics. So this picture on the left is probably the most valuable picture. So if you look at her, what do you see as she's going into a single leg squat? So this is an exercise where she was doing a single leg jump off of the box into a single leg squat or chair tap, however you want to term it. So you can see she's going into knee valgus and foot pronation on that working limb. And then you look up higher and she's got a trunk collapse. So we know that these areas of collapse down the chain are going to almost guarantee a patient some sort of injury or decreased performance if she doesn't get injured by some miracle. So these are things you have to address. You can't just send your patient off to do these exercises on her own. You've got to be there and you've got to be picky on these details. And then you see in the next picture a ladder drill, and at the end of the ladder drill she was completing a box jump, and we kind of would play around with the height and play around with the ladder drills that we were doing there. So here's my references. Thank you for your time, and please ask us any questions you may have.
Thank you all. Very good presentations. So in the questions, first one, Mary, is there an athlete or a sport that you might not want to use a quadriceps autograft in, like a repetitive jumping or a cutting sport?
I don't think there are any sports where you absolutely could not use a quad autograft, but you definitely you have to take their sport into consideration for sure. And so for patients that are doing repetitive jumping, that may be a consideration. Certainly if they've had like chronic quad tendonitis, if they've had some other type of extensor mechanism injury, if they've like previously had a patellar tendon injury or whatnot, those are all factors you have to take into account absolutely when trying to decide if a quad autograft would be appropriate.
Krista, when would you start a stationary bike in a 14-year-old?
So beginning stationary bike, there's some controversy about this among clinicians. I never use the stationary bike for range of motion. So you've got to consider how that patient is progressing through her range of motion. But then with a 14-year-old, you want to think of, you know, is she prepubescent or not? And you've got to consider the healing time for the bony tunnels. So, you know, you probably don't want to initiate anything with confidence until week 6. But of course, every patient differs in how she moves through puberty, and then considering healing times for different patients.
And Dr. Mulcahy, what's the disadvantages of the patella tendon graft?
So some disadvantage, and being honest, it's certainly all 3 of the most common grafts, you know, hamstring, quad, and BTB definitely have their pros and cons. But specifically with regards to the patellar or BTB, there's a risk of patella fracture, and that definitely is taken into account is one of the big ones. I mean, there's technical aspects, like if you don't have a lot of familiarity with it, there are issues with, you know, graft tunnel mismatch and length, which can create a lot of stress intraoperatively. But patella fracture, risk of patella fracture is definitely of high concern, especially if you don't do that procedure frequently. And, you know, there are things that we can do to try to decrease that risk, like bone grafting the patella after harvesting that plug and making sure that you're only taking out as much as you need, being very careful as you harvest that plug. And then having also another common one is kneeling pain after the surgery. So that's probably one of the most frequent things that patients will complain of. And so that's important to take into account depending on the patient's sport as well.
Thank you. So Renee or Taylor, outside of the FIFA 11, what other ACL prevention programs are out there, and what would you recommend?
To be honest, the FIFA 11 is probably the one that I'm most familiar with. I don't know that I could give you the specific name of another one right now, but I would be happy to help with that. FIFA 11 is definitely kind of my go-to, and I even when I have athletes come into the training room for something unrelated to a knee injury or ACL, I make sure that I am incorporating exercises that I think will help with that, you know, going back to eccentrics of the hamstring, balance, strengthening, anything like that, proprioception. I'm making sure to incorporate that in any type of rehab setting that I have going on.
Taylor, anything else? You're muted.
I would say that FIFA 11 is probably the one that has been my go-to as well in my personal practice, also the athletic trainers that I know. So I agree with Renee that plus I feel as though it has the most research behind it. So I like to do evidence-based practice as much as possible. So I would definitely suggest the FIFA 11. There are some additional programs out there, but I don't know if they're as highly researched.
So, and this may be to the whole group. Are there any studies out there that you're aware of that address race in relation to modified risk factors?
Not that I know of. It's a very good question.
So from the standpoint, so this is probably going to be Krista. I'm going to kind of two at once. Is getting the gait pattern back to normal one of the most important things in the first 2 weeks? And at the same time, and then I'm going to go back while you're doing on the stationary bike, why would you not use it for range of motion? So gait pattern first.
Okay, so gait pattern, yeah, gait pattern is important right off the bat because how's the patient getting around? She's walking around. So you don't want a patient to begin this funky pattern that she's just going to implement all along. And load acceptance throughout the limb is going to be important. I've had patients in the past who are still trying to use their crutches at 1 month post-op, and it's just because of a fear avoidant behavior. So you've got to start that early and get the patient learning how to accept the load through that limb early. And then if you can normalize the gait pattern, then you've got proper firing of different musculature. So in a normal gait cycle, you need proper activation of the quad and the glutes. And these are all things that we're working on. Now we can work on them in isolation, but everything is going back to function. So why not begin to focus on that function early? Now, of course, there's some patients where, no, you're not touching that. She's swollen. She's in a lot of pain. Her quad sucks. Her range of motion sucks. No, we'll get to the gait, but it's just, it's dependent on the patient. So then you asked about the bike, for range of motion. So bike for range of motion, what you're going to see, and I wish I was standing in front of you right now so that I could show you, but if you use range of motion or you use bike for knee flexion, you're going to see a compensatory pattern of like a hip hike and a trunk shift. And it's going to look ugly and the patient's not going to like it. And it's not promoting the normal arthrokinematics inside of that joint.
Perfect. Thank you. So Dr. Mulcahy, if an athlete's already had 2 ACL surgeries and used quad tendon, then bone, patella tendon, bone, what are the risk factors and things that should be addressed as you're coming back and looking at either the second surgery or if they tear again? What are the kinds of things that you're thinking about with regard to the surgical intervention?
So yeah, it's a very complicated situation. Of course, you know, we're looking at multiple factors in those patients. Like, of course, you're looking at technical aspects. It's very, very important to look at limb alignment. So we're getting full leg length films because alignment can contribute to failure of the ACL. We also want to look for things like a root tear. So a meniscus tear at the posterior aspect of the meniscus where it attaches to the bone. that can be missed and that can be contributing. A ramp lesion, sorry, is also what I wanted to comment on. A ramp lesion is a tear of the meniscus where it attaches to the capsule. And unless you look for that, you can often miss it. And that can absolutely contribute to a recurrent ACL injury. And then, of course, looking at the biomechanical factors, et cetera, like the things that we can have an influence on. So we want to take all of those things into account to try to identify what it was that was that contributed to that athlete's recurrent injury, and whether it's appropriate, what the most appropriate next step is. So whether it's, revision ACL and trying to continue sport, whether it's revision ACL and not going back to sports or focusing on another sport, or if at that point, depending on the age and activity level, whether the patient is just done with surgery, not wanting to have another revision procedure.
Okay, back to Krista. You talked about physical therapy. Would you talk about getting physical therapy prior to 2 weeks? And then don't go away. I got another set of questions for you.
All right, so yes, as I said in the presentation, you're usually seeing these patients post-op day 1 and maybe as late as post-op day 7, sometimes because of complications, post-operative complications, or even insurance limitations. But I want to see that patient. I want her to have surgery today, and I want her to walk into my clinic tomorrow, because even though there might be some differences in what you can do, education is key in this rehab, and you can always educate a patient regardless of what she's able to do physically.
And then, you talk about maintaining full extension. Is there a specific angle that's full extension, or are you just comparing this to the contralateral side?
So you're comparing this to the contralateral side. In the slide where the patient was lying prone and you could see a difference in heel height, that side-to-side difference, that's kind of what I use as my go-to. Because if you just restore knee extension to 0, but the patient has 7 degrees of hyperextension on the contralateral limb, what do you think her explosion is going to look like when she's coming up to at the volleyball net to block something? It's going to look poor, and it's going to lead to asymmetries in her hips and core.
All right, Renee. So when you're looking at some of the prevention programs, what's the ideal age to start these programs at, and when's the best time of the year as far as the seasonal aspect to do these?
Okay, so as far as an age, the earlier the better. I believe one of the articles I was reading discussed the age of 14. You want to get these girls really before they start developing, hormones are changing. The research has shown that it's more effective to do a preventive training program in a younger athlete, such as like a high school or middle, compared to collegiate or professional. That's not to say that it's not effective for a collegiate or a professional athlete, but at that point, muscle memory and control and habits are already established at that point. The sooner that you catch them, the better able you are to help them develop good landing patterns, good strength, quad control, hamstring control, but I believe around 14. And then as far as when to do this, literature has shown that preseason alone is not good enough. In season would be great. Even better than that would be preseason and throughout the duration of your playing season. And if you can do it before every training session, that's ideal as well. Even if you're doing FIFA 11, like we talked about, parts 1 and part 3 prior to games.
Thank you. Taylor, as we're looking at the whole prevention program and really trying to figure out how do you get coaches and parents and the athletes and everyone to buy into these programs, what's the best way of going about that?
So I kind of think it starts with that money number that Renee presented. at the beginning of the presentation, that $83,000. I think most people want to avoid that. But on top of that, we want to make sure that this isn't just about the prevention of ACL. This is also about strengthening certain muscle groups that are going to prevent other injuries as well. We're talking ankle injuries. I mean, I know some people use FIFA 11 not just for soccer athletes, but we're utilizing this to make sure also we're having good core control, because that's going to help a lot of other things and a lot of their skills going forward. So we want to talk about building a better athlete and a more whole or well-rounded athlete. So getting your coaches to buy in on that. I know it is difficult, as Renee talked about, getting some time from your coaches to implement this into the practice. But I think that if you're willing to show them the research on how it's effective, show them the reasoning behind it, and telling them, you know, these athletes won't miss as much of the season potentially due to injuries if we do take this extra 5 minutes or 10 minutes at the beginning of practice. I think that that'll resonate more with them. I don't know if Renee has anything else to add, but I think those are a few things to get some buy-in, some key things.
Just to kind of piggyback on what Taylor was saying, conversation is and understanding is key. You need to sit down, take the time out of your day, out of your coaches and your athletic directors, and even at your parents. Sit down and have those conversations. The more that people understand why this is so important and how it can be accomplished, and you're not only benefiting the athlete in the short term, but in the long term. If you can prevent a knee replacement, osteoarthritis, anything like that 25 years from now, that's just as important as the short term of preventing the actual ACL tear. Communication in any regard, like Krista mentioned, is just important. Like if you don't have that, you don't have the rapport, you really have nothing. So just to kind of piggyback off of what Taylor said, it's all about taking the time to address those things and sit down and have those conversations.
Thank you. Dr. Mulcahy, are certain ages more at risk throughout the menstrual cycle, or is the risk level the same regardless of age?
So certainly once girls are menstruating, like that risk is higher just because of the cyclical nature of, or the fluctuations of hormones. And so that's really why ideally we would, these types of programs would be implemented before girls go through puberty, so they can develop good habits before the natural sort of bad habits would develop, the sort of natural biomechanics of girls. But in terms of a specific age or whatnot, no, I think once menses have started, there's no higher risk in a 12-year-old who's menstruating than a 17-year-old. But I think we can have a higher influence on the younger age girls, as Renee and Taylor, et cetera, have touched on.
Thank you. One more question, and then we're going to come back to the panelists to see if they have anything else to add. Actually, maybe two questions. One, is there a certifying body for the FIFA 11?
So FIFA is really the one that developed and implemented this and put out the literature and the research. It was established by an international group of doctors that have a lot of experience with ACL tears. So it is coming from FIFA. But again, like Taylor mentioned, I would say that it's probably one of the most widely researched and accepted programs that there is, but it definitely is coming from an international group of doctors related to FIFA.
And then anything else from the panelists that with the questions or other thoughts with where we are as we begin to wrap this up? I'll start with Dr. Mulcahy.
Well, I think, there's been certainly a lot of great information shared, and I have learned a great deal from Krista and Taylor and Renee in their presentations as well. So I think just key points to take away is that our female athletes in general are at much higher risk, and that we need to take those risk factors into account and try to do all that we can to implement injury prevention programs, even on a small level. Like Renee is saying, before practice is very effective, but it does definitely in certain situations take a lot of effort. So I think we've made good progress. We still have work to do, and I think we can continue to improve, especially if we start by focusing on the highest risk athletes. So those girls playing soccer, volleyball, basketball, et cetera, starting there, and then moving on to our other athletes. Because as Renee and Taylor have really emphasized, these types of drills can be very effective for all of our athletes, regardless of sport. But if we're trying to get buy-in, we can start with the highest risk athletes.
Thank you. Krista, any parting thoughts?
So I think that it's just important to remember who your patient is. We all have access to the research and the literature, which is crucial in developing a plan for physical therapy after an ACL reconstruction. But you've got to know how to communicate that to your specific patient and how to get her to those goals. And then the other little piece of that is communication with athletic trainers and physicians. That will get you very far, because that collaborative approach, it will keep your patient engaged, and it will let your patient know that you really care about her recovery. And then it'll just let everyone know that you're on a team, and that just goes a really long way.
And Renee, while your microphone is unmuted, we'll come to you and then to Taylor.
Okay, sounds good. So I just would takeaways and just things to remember. Start this at a young age. Incorporate it preseason and in the duration of the season. You want buy-in from all of those involved. The sooner that you get the buy-in, the more effective it's going to be. Compliance is key. Along with compliance is the fidelity control that we talked about, which means making sure that the exercises are being done properly. Again, if you're not doing them properly, then you're really not getting the benefit that you could be doing. Provide feedback, whether it be visual, verbal, both would be great. People are going to learn different ways. So you need to cater to your specific athlete, your specific team. And again, like we talked about, just sit down and have those conversations to help people understand why it is so important. If you can avoid osteoarthritis, a knee replacement, an $83,000 bill throughout a couple of years, that would be ideal. And yeah, just stay safe, keep your athletes healthy. Thank you.
Taylor?
So I think it's just important to remember that there's external factors that we can't control, such as, traumatic injuries, getting hit, things like that, that, are not in our, again, like I said, not in our control. But there are internal factors that Dr. Mulcahy talked about, that Renee talked about, that Krista talked about, that we can control through the programs that we implement. I think we've gotten really good at rehab programs and knowing what's successful, but I think prevention programs are the key in helping the female athlete, especially with those internal factors that we don't know as much about or that we can't control. So just make sure. I'm a huge believer in prevention, and I think that that's important. And again, like Renee said, the buy-in is huge. So yeah. Thank you.
Perfect. Thank you all very much. Want to thank all of the members of the panel and presenters today. Very good presentations, very interesting. And with that, I'm going to turn everything back over to Tess for the final closing statements. Thank everyone for attending.
All right. Thank you again to the Tulane Women's Sports Medicine team for joining us today. To participants, in the upcoming days, you will receive an email with the assessment and evaluation for today's webinar. Upon completion of that evaluation, you will receive your statement of credit or certificate of completion. If you have any questions in that process, a couple of days have gone by and you haven't received an email, please feel free to email your inquiries and questions to centerforsport_education@tulane.edu. And a couple of other things, if any upcoming events, you can find them at the Center for Sport Education tab. And the webinar recording, so including the recording today, will be available on the Tulane University Center for Sport YouTube channel. So if you would like to, watch the recording again, go back and listen to any of the presentations, it will be available there for you. And then stay connected with us. So you see the social handles for the Center for Sport as well as Dr. Mary Mulcahy listed there. So please keep in contact with us and join us for our upcoming events. And with that, we will exit this webinar. Thank you all for attending.
Thank you very much.